This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. We've been doing this podcast now since October of 2016, coming to you, trying to go through initially all the content specifications for pediatric hospital medicine, and then we became a subspecialty and we went through all the American Board of Pediatrics, their requirements for us to be a specialty. We've been interrupted with COVID, and we are back trying to cover some pediatric topics. Today, I'd like to cover one of the more bread and butter topics we see in peds all the time on the inpatient side. And to do that, I have a very special guest who I'm going to introduce, but it's a topic you know and love. It's BRUE, Brief Resolved Unexplained Event, covered on the boards of part of our content specifications from the American Board of Pediatrics. To cover it, I know I couldn't have gotten a better guest, and I'm very fortunate. I'm happy he's with us. I'm going to introduce him now, Dr. Joel Teeter, MD, MPH. He's an associate professor of pediatrics in the Division of Hospital Medicine at Seattle Children's Hospital and the University of Washington School of Medicine. He's a board-certified pediatric hospitalist and recognized as a national leader in quality improvement, education, and research, and a leading expert on the topic of brief resolved unexplained events. He has published over 60 peer-reviewed articles and book chapters, over 20 of which address the topic of BRUEs. He currently serves as the chair for the American Academy of Pediatrics Council for Quality Improvement and Patient Safety, which does oversee the development and implementation of AAP clinical practice guidelines. He's also chair for the AAP subcommittee on Brief Resolved Unexplained Events, BRUEs, which published clinical guidelines in 2016 that coined the term BRUE and provided recommendations for lower-risk infants. Most recently, last year in 2019, he co-authored a framework for the management of higher-risk brief resolved unexplained events published in Pediatrics. He led many national research projects aimed to improve the quality of care for hospitalized children and is currently the principal investigator for a 15-site QI study aimed at evaluating and improving the outcomes of infants who have experienced a BRUE. So, Joel, thank you very much for taking the time out to join us today.
Thank you, Tony. It's a pleasure to be here.
So, why don't we start with getting some of the paperwork out of the way. We'll do our disclosures. I will go first, and then you can go. I have nothing to disclose.
And neither do I. I have no disclosures.
Joel, we were talking yesterday to prepare for this podcast, and you told me a great story about you were giving a lecture and someone came up to you and introduced himself to you. Would you mind going through that?
Yeah, it's a great story. I was presenting at the American Academy of Pediatrics National Conference on the topic of BRUE, and it was shortly after the guideline was released. And after I did the presentation, a gentleman came up to me and introduced himself, said his name was George Little, a name which I instantly recognized. And he was the author of the NIH consensus statement, which coined the term apparent life-threatening event. And I sort of froze, was a little concerned that he might have considered my work to be critical of his work, since the work that our group did replaced a term that he coined in the 80s. And fortunately, that wasn't the case. He really was excited to see the work and, as he said, the evolution of the work that they began. And what was interesting about what he said was is he provided some really important historical context for me, in that, he said in the 80s, he was a perinatologist. Him and many others, researchers like him, were really struggling with sudden infant death syndrome. Thousands and thousands of infants were dying of unknown cause. Parents were worried, physicians were worried, and there was a huge national effort to try to understand the causes and prevent the sudden infant death. And to do that, particularly from a research and clinical standpoint, they had to work on the terminology and come up with some specific definitions. And at the time, infants that had an event that were brought in for evaluation were called near miss SIDS. And his group, realized early on in their conference that they had that term wasn't going to work. That, as a diagnostic term, one could imagine receiving that as a diagnosis as a parent and the difficulty that one might have in going home with that as a diagnosis. And they also knew that it probably wasn't true, that it wasn't near miss SIDS, at least to some degree, and they didn't know to what degree that was. So they came up with the term apparent life-threatening events. And their intent at that time was really, as George said, was to define the concern, or another way to say it, the chief complaint that the parents had when they brought in the child. They didn't really intend it to be a diagnosis. And interestingly enough, he acknowledged that it did become a diagnosis, for the subsequent 20 years or so after that. Like I said, that was not his intent. And the other thing he reminded me was that statement was published in 1986 and it expired in 1991. And they didn't readdress it.
It expired 5 years after they did it.
Yeah, and if you Google it, you will see in black and white, which I don't know why the NIH puts it in black and white, maybe to indicate that it's expired, that it is in fact expired. It highlights that this has been expired, and it's only there for historical purposes only.
Oh, wow.
I think a lot of us that do quality improvement would love to have that problem, which is that people adopt things, even when you perhaps don't intend them to, but to adopt them so widely as the term was adopted. But that was not their intent, and I think they expected somebody to come along and do the work we did, according to Dr. Little. The other interesting anecdote to that is he asked me if I knew his daughter, and when he said her name, of course I realized she was a chief resident with us, and I had worked quite closely with her. I don't understand why she never explained who her father was to me when we worked together. And then the best part of the story is his daughter is a pediatric hospitalist in Portland.
Sure she is. But what I love about that story is it does highlight, and actually it may be something that's important for us now. This was a problem they had, SIDS, that they did not really understand nor know very much about because it was relatively new. And they had to do something to help physicians and help those taking care of the kids. And the unintended consequence of addressing it in some way is they had this term that lasted for 20 some years that then we had to update. But I guess that leads into my next question for you is, why did you feel throughout your career up to this point that this term needs to be changed? And then we have to take it a different way.
Yeah, it's a great question. The term does describe very non-specifically a concern that a parent may have of an observed event. In medicine, and particularly in guideline development, you need specificity around a condition. And so if there's lack of clarity about what the condition is, then it could be misapplied to all sorts of scenarios. And I think this can be seen in many problems that hospitalists deal with. The definition of Kawasaki's has changed over the years, and COVID-related conditions and problems related to that change perhaps daily.
Yeah.
And so when we're trying to understand the problem, it's hard to come up with a solution, right? And so really defining the problem is critical. And that's where we knew there was a problem with the term apparent life-threatening event, is when our guideline committee at the AAP got together. Really the first thing we all identified was the problem and working with that definition, both as a chief complaint and as a diagnostic term, which it had, as I mentioned, become.
So now you guys decide to go after it. One of the things I didn't ask you is how long for when you started, okay, we're going to look at this event. We're going to look at ALTE, apparent life-threatening event. We're going to update it. How long of a process is that from start to finish to when you release the guideline?
Oh, wow. Well, I can tell you it's longer than we anticipated.
Okay. That's usually the case.
In general, the AAP targets a 2 to 3 year period of development for guidelines. My recollection is that it was about a 3-year process.
Okay. So not terribly long. And one of the differences I'd like to highlight in terms of the differences between ALTE and BRUE is I remember being a resident and being trained. I remember my program director always asking the same question: what is your definition for defining, how do you define ALTE? What is an ALTE? And one of them was if the parent feels that the child's life was in danger. So it's such a general thing. It describes a chief complaint. Then you have to figure out why it happened. So ALTE does describe a chief complaint, but BRUE is different, right? BRUE is a diagnosis of exclusion. Am I correct in that?
That's correct.
Which, I have to be honest, for those listening, when in preparing for the podcast, when Joel and I were talking yesterday, that was the first time I had realized that, because I think I just assumed it was similar to ALTE in that it's a chief complaint. And you have to figure out why the patient's in, but it is actually, if you've ruled out everything else, as we're going to go through, a diagnosis of exclusion, which is nice. I didn't know that. Now, in looking at your guidelines, and for those of you at home listening, what we're talking about is Brief Resolved Unexplained Events, formerly apparent life-threatening event, and evaluation of lower risk infants. I looked at both the executive summary and the full version. This is by our guest, Joel Teeter et al. These are the clinical guidelines in pediatrics in 2016. On the executive summary, there were 2 primary objectives. On the full version, there's 3 primary objectives, but for the executive summary, they kind of crunched 2 of them together. So I'm going to read the 2 primary objectives of the guideline. The first is they want to recommend the replacement of the term parent life-threatening event, ALTE, with a new term, a BRUE, Brief Resolved Unexplained Event. And the second is to provide an approach to evaluate and for evaluation and management that is based on the risk that the infant will have a repeat event or has a serious underlying disorder. Did I summarize that right?
Yeah, no, that's exactly right, John.
So before we get into the definition of BRUE, I want to talk about Table 1 in this guideline, the clinical practice guideline, because we talked about it a little bit before, but I have gone through guidelines before in this podcast, and this table is shocking. Because this is the table we all see in a guideline for the summary of the key action statements, and then usually gives you the evidence quality, strength of recommendation. And one of the things we've constantly talked about in pediatrics is most of our guidelines do not have good evidence for what we do. This is drastically different. The overwhelming majority of the recommendations you make have moderate evidence to strong evidence, and the minority have weak. And in fact, it's easier for us to quickly read which ones have weak evidence because everything else is strong or moderate. The weak ones are need not admit infants to the hospital solely for cardiorespiratory monitoring, may briefly monitor patients with continuous pulse ox and serial observation, may obtain a 12-lead EKG, need to obtain neuroimaging, CT, MRI, or ultrasonography to detect child abuse, need not obtain a UA, bag or catheter, need not obtain respiratory viral testing if rapid testing is available, may obtain testing for pertussis, need not measure serum lactic acid or serum bicarb, and need not obtain a measurement of blood glucose. And for those of you at home, if you've forgotten, I'll remind you. So a moderate recommendation is level B into level C. Level B is trials or diagnostic studies with minor limitations, consistent findings from multiple observational studies. And level C is single or few observational studies or multiple studies with inconsistent findings or major limitations. So that's your moderate recommendations. Your weak recommendation is usually based on low quality evidence and expert opinion. So it's level C, then level D for weak recommendations. So Joel, that had to be nice working with such good data that you can make these guidelines with.
Yeah, it's what was clear when we did the systematic review of, and I can't remember the exact number of articles, but I think it was around 1,000 articles that we had to sift through that pertained to apparent life-threatening events. When we sifted through those apparent life-threatening event articles, so they use that term to define it, we had to find within them the BRUE subpopulation, if you will. And really, there were only a handful of articles at that time that really related in the way that they needed to the BRUE population. But I think there was enough to identify the patients that didn't need a lot, that really looked like they were at low risk. And that's where we came up with the term lower risk. What we struggled with as a group was there was then everybody else that wasn't lower risk. We called it higher risk because it was relative to the lower risk. And I think this is an important point. They're not high risk. So they're not at an elevated risk. Just compared to the lower risk, they have an elevated risk. But that so-called higher risk group, we really couldn't quantify. Even the population that existed of the patients in the study, we really couldn't say what the risk for any outcome was. But like I said, there was great evidence to say, well, at least with this lower risk, we can at least say what not to do, which is quite different than most guidelines, right? Most guidelines say, we're trying to identify the high risk group, and this is what you need to identify that high risk group. This is a little bit different. Here's the lower risk group, and this is what you need to do to find the lower risk group.
Well, and for these guidelines, I remember being a resident and admitting ALTE patients over and over and over. And then what not to do saved a significant amount of admissions, because there were many days I remember where ALTE patients were the bulk of my service. And I was just going through, and in the morning I would tell the families, oh, your kid did well, your kid did well, your kid did well, everyone's going home. And it was like a turnover completely. So it was needed. I mean, it was very helpful.
Yeah, well, Tony, I think you described exactly why I got into doing the research that has gotten me here, so many years later. It started in my residency, where my third year as a senior, I think it was my last rotation before moving on after residency. And I was really questioning where this term came from after spending 3 years admitting these patients without a clear indication as to why. And there was certainly a well bias, right, based on my experience and your experience, in that most of the patients seemed to do quite well. And yes, we could remember one or two cases where there was something serious, but it always felt, at least to me, how many patients do we need to hospitalize to detect that one or two serious cases? And so your story really was the same, or your experience was the same thing that really inspired me to try to solve this problem, because I felt like the definition wasn't doing the condition justice, and I felt like we really needed to understand the risk better. And, at the time, we needed to start with the available evidence, and that's what we did. I think now we know a lot more. And now that the BRUE guideline has come out, have been multiple studies that demonstrate how safe it is, particularly the lower risk patients, to not do testing and not do hospitalization. And in fact, there's one study out of, I think it's out of Pittsburgh, that demonstrated that there's been a decrease in hospitalization and decrease in testing since the guideline came out.
Yeah. Yes, and I think that's helpful to have to show that the guideline's working. Anecdotally, for the residents and fellows who happen to be listening, however many BRUEs you feel like you're admitting, I guarantee you, Joel and I admitted many, many more ALTEs. Many, many more. I know sometimes I have residents that'll tell me, oh, it's like I'm only admitting BRUEs, and I tell them, no, you're not. No, you're not.
Well,
go ahead.
Oh, well, I was just going to say, I've had the fortune of traveling across the country to talk about this, and I am amazed at how the hospital systems approach this problem differently. Believe it or not, there's some hospitals that admit every single ALTE, not only to the hospital, but they admit them to the ICU for various reasons. And so I've been amazed at how many intensivists have come up to me to congratulate me and thank me for the work that we've done in carving out the lower risk group.
I didn't know that. I did not know people would send them to the ICU. All right, why don't we talk about the definition of BRUE as per the guideline we just read out. And I'm going to read it verbatim. An event occurring in an infant younger than 1 year old. The observer reports a sudden, brief event which is resolved by the time I or another hospitalist or ER doctor see them. And to qualify as a BRUE, it has to have equal to or more than one of the following: either cyanosis or pallor, absent, decreased, or irregular breathing, marked changes in tone, either hypertonia or hypotonia, and altered levels of responsiveness. And this BRUE is only diagnosed when there's no other explanation for a qualifying event after conducting an appropriate history or physical. And again, the diagnosis is based on a clinician's characterization. So the family tells you, you listen to the story, you examine the child, and then you make the diagnostic decision that this is a BRUE, ruling out if there's a fever, clearly it's not, there's some infection going on. In your guidelines, you talked about the importance of pallor and the irregular breathing and the altered level of responsiveness as compared to ALTE. I remember reading a section on it that pallor was a different thing that you put in because of how often it was talked about in the literature. Is that right?
Yeah, that's correct. Yeah. So first of all, the characterization of the event is critical. You really do need to spend, as a clinician, ample time discussing with the family what the events looked like, right? Because these are observed events, and you need to take what their experience was, characterize it into medical terms. So you mentioned color change was the old term. And what we really wanted to focus on at the committee was turning blue was obviously one of the things we were worried about because that indicates cyanosis. Turning red, which could have been qualified under the old definition, really we felt was not an indication of a disease or a problem. In fact, infants do that all the time with something as simple as choking or gagging. Pallor was an interesting discussion, but we did feel that episodes of pallor could indicate a substantial problem. And so that's where we really ended up with specific color change of either turning blue or turning white, if you will.
And now the guidelines, they'll go further. We'll talk about the recommendations on management for infants who qualify as lower risk. But they state that there's not enough evidence for those who qualify as higher risk or have already have another diagnosis to where there's a guideline specific to their presentation. And then after this, so the beginning of the guidelines really talks about what you guys did and how you did it, and then the term ALTE. And then we get to figure 1. Now, figure 1 is very, very noticeable to any hospitalist or ER doc or primary care doc, because it's the flow chart all of us turn to, especially when this was first published in 2016, to remember what we do with our patients and who. And I have to tell you, I like it a lot. I like it a whole lot. So we're going to first talk about who is characterized as lower risk based on your criteria. So the first is the patient has to be older than 60 days, and they have to have a gestational age greater than or equal to 32 weeks, and a post-conceptual age of greater than or equal to 45 weeks, an occurrence of only one BRUE event, so no prior events ever, and not having the events in clusters, like that specific presentation. The duration of BRUE had to be less than a minute. No CPR by trained medical provider, and that's always a sticking point, which we can discuss. No concerning historical features, and no concerning physical exam findings. So I guess going in order, you talk about in your guidelines, kind of lumping together the age of the patient that had to be older than 60 days, and then the gestational and post-conceptual age, because younger infants and infants who are more premature can have different presentations for more serious events. So you didn't want to count them for this. Did I read that correctly?
Right. Yeah. So there was evidence that if you were born premature, that over time that prematurity would not be a risk factor or wouldn't be counted towards your risk. What we did find is that if you were born under 32 weeks or 32 weeks and under, that your risk would not attenuate. So any preemie that was born under 32 weeks is automatically not going to be in the lower risk group. Now, if you are born above 32 weeks and you've lived long enough that you've corrected to greater than 45 weeks gestation, then your risk attenuates and you can then qualify for lower risk.
Now, even though your guidelines clearly state no CPR by a trained medical provider. I can tell you one of the areas we always get stuck on is the parent. They come in there and they were terrified in the ER. They come up to us on the floor. They were a little calmer. Either a parent or a caregiver or someone attempted CPR on the child, and they do not know CPR. So they used whatever they learned on television, and they began blowing on the child or blowing in their mouth or doing some type of compression thing, and then the child woke up or came to, and so they're adamant that that's what it was. And I can tell you, we've got stuck a number of times just saying, okay, let's observe the child overnight, just from parental fear and anxiety. Now, is that something you all talked about? Have you seen that yourself?
Mm-hmm. It's a great question. So in the ALTE literature, which was all we had available to do the 2016 guideline, they didn't really distinguish very well whether the CPR was indicated or not. And rightfully so, right? It's a little bit hard even when you're taking a history to know whether it was indicated or not. So we used it as best we could, and in the evidence that was available, it seemed to indicate that CPR was a risk factor. I think probably there are many cases when CPR is used and it's not indicated, and that if you can discern that in your history, then I don't think that qualifies you to be in one risk group or the other. I would just say that CPR was not indicated, and I wouldn't consider it in your risk stratification. I will say what we've learned now through some of the research we're doing is that the indication for CPR actually matters. So what I think most of us, when we talk about CPR, what we're thinking is they had chest compressions. But CPR can also be airway clearance. And so if you take an infant who's choked or gagged on whether it be, formula or vomit or, learning to eat solids, and the parent does airway clearance maneuvers and clears the airway successfully, I'm not sure that, first of all, qualifies for the CPR that we're talking about. Second of all, it really doesn't qualify for a BRUE because you know what happened. The patient was choking and they did airway clearance and then they're better. Or even if they aren't better, you know what caused the problem. And so it's important to remember that a brief resolved unexplained event is unexplained. And so if you can explain it, then really this becomes a moot point.
And you did mention what I glossed over, but I think it bears repeating that the history and physical exam in your guidelines, in both the guidelines and then the recommendations on higher risk patients, is stressed that that this is the most important part of this is taking a very thorough history and physical, asking detailed questions. And in fact, in the next paper, there's a whole list of table 3, I think. I really liked it a lot. But I wanted to repeat that again, just for the audience at home. Now, marching down figure 1, we've gone to the risk classification. If your patient risk stratifies to lower risk, then figure 1 really does a very nice thing and goes off in the 4 boxes in what you should or should not do or may or need not do. And should is educate the caregivers about BRUE and engage in shared decision-making, the guide evaluation, deposition, and follow-up, and then offer resources for CPR training to caregiver. What I didn't read and I wanted to know, I know about the evidence in the adult literature of bystander CPR. Is that the evidence you used for the CPR recommendation, or is there specific infant bystander CPR or parent CPR evidence you used?
That's a great question. And no, the studies that we used did not have the level of detail to really indicate, again, the quality of CPR or the level of training. I do think in the future, it'll be important to better understand that.
And then for what you may, so that's what you should do, just education and offer CPR training. What you may do is obtain pertussis testing and a 12-lead ECG, and then briefly monitor patients with a continuous pulse ox and serial observations. And the pertussis section, it did talk about knowing your local patterns if there's an outbreak in your area locally to consider it. Did I get that right?
Exactly, yeah. So, for example, in Seattle, we have a large unimmunized population. And it is not uncommon for us to have an infant come in with a BRUE presenting, just with what seems to be apnea and pertussis being the cause. So if you're in a place like Seattle where there's either a lot of pertussis or there's an under-immunized population, then you certainly should consider pertussis.
And then briefly monitor is, I believe, 1 to 4 hours is the recommendation for low risk. And then 12-lead EKG or ECG, depending upon where you are, how you pronounce it. Then should not is obtain a white blood cell count, blood culture, CSF analysis or culture, serum sodium, potassium chloride, BUN, creatinine, or calcium, which is a BMP for us, ammonia, blood gas, urine organic acid, plasma amino acids, or acylcarnitines, chest x-ray, echo, EEG, studies for GERD or laboratory evaluation for anemia, initiate a home cardiorespiratory monitor, prescribe acid suppression therapy or anti-epileptic medications. So those are what you should not do for these low-risk patients for BRUE, which makes sense. But again, for ALTE, we used to have lots of patients who'd get a CBC and a BMP in the ER, possibly a chest x-ray, and then maybe even started on Zantac if they felt it was necessary. But all this workup that was done, and this really eliminated that, which was very nice.
Yeah. No, you're exactly right.
And then need not do is respiratory viral respiratory test, your UA, blood glucose, serum bicarb, serum lactic acid, or neuroimaging, and admit the patient solely to the hospital for a cardiorespiratory monitor. Only admit them for cardiorespiratory monitor. And so, in one fell swoop, this eliminated a lot of what I was doing for ALTE. So I have to tell you, I do appreciate it. Is there anything about the guidelines, these specific guidelines that I did not talk about that we should talk about?
Yeah, put a couple fine points on things, Tony. I think it's really important that people realize to have a BRUE, that the patient is essentially well appearing when they present to the provider. So if a patient comes in and they have a fever, they're actively coughing, they're actively having work of breathing, then it's not a BRUE because they're objective signs of a disease. And so you should diagnose and manage a patient according to those symptoms. So the idea here is really that the symptoms are resolved, the patient is well appearing when they get in. And then you really need to do, as you mentioned, a very good history and physical exam to elicit any other risks and to better understand the event. So that we have published, as you alluded to, what the appropriate history and physical exam looks like. And I think it's critical that people do spend the time to evaluate those things, because in the end, it can save the patient unnecessary testing and it can save the patient unnecessary admission. And in fact, it may even identify some of the scary, serious underlying disorders, such as child abuse. And one of the things we found first of all, we know that infants that have child abuse can present with a BRUE, or in the prior ALTE literature, they could present in that way. And that most of the time, a good history and physical can detect the risk for those patients. And so those are really, I think there's a lot of value in spending that extra time to identify those at-risk patients.
That's a great segue. I think I feel like into the next paper you were on the team for a framework for evaluation of the higher risk infant after a brief resolved unexplained event. Because this paper I spent a fair bit of time on looking at. So it starts out, for those of you at home, this was published in Pediatrics in 2019, of volume 144. So it starts out initially going back through the definition of BRUE and the definition of low risk BRUE, which we did. And then they talk about the evaluation and management of higher risk infants is challenging because there are many potential causes of a BRUE, and there's just a dearth of evidence to support using clinical factors to quantify risk for adverse outcomes, such as recurrent events or diagnosis of a serious underlying cause. But before we get into that, Joel, I think it's important. This paper was not a guideline. This was a guidance. Is that correct?
That's correct. Yeah. So this was, as we mentioned, there was not a lot of evidence to support how to manage this other group, which by default we termed higher risk. There was enough clinical consensus, but what our concern was is that this still really represented a heterogeneous group, and that there were likely patients that were still at low risk and probably didn't need a lot of testing, but we didn't have enough available evidence to support really making clinical recommendations using high quality evidence, which is really the criteria for doing an AAP clinical practice guideline. So what we did do, because there was really a lot of demand for it, is members of the subcommittee put this together, and it represents a bunch of subspecialties, including cardiology, pulmonary, child abuse. And this is what they could come to consensus on based on their understanding of the prior literature and how they would recommend their patients be taken care of with these conditions.
Yeah, it almost sounds like you went through a process similar to what you would do to make a guideline in terms of getting all the appropriate players in the table or in the room talking, just there wasn't the evidence you needed.
That's exactly it. In fact, it was, the same people that reviewed, or at least a subset of the people that did the original guideline, and they used the available literature and some updated literature, although I don't think it swayed the recommendations much, but it did, it included at least the stakeholders and the subspecialists that would, be worried about certain problems in their, in their area that we would be missing. So the neurologists who are trying to identify seizures, the child abuse doctors that are trying to identify abusive head trauma in this population, the metabolic geneticist that's trying to identify metabolic genetic disorders that get through newborn screening, et cetera, et cetera. So we had all those groups represented, and it was nice in that we had already worked together on the guideline and we had good knowledge. And then we also had a process for reaching consensus that we used, the same process that we used for the guideline, we used for this.
Table 2 kind of hit me in the face when I was reading the paper because you arranged, the arrangement of the table is not in alphabetical order. So child maltreatment is first, then GI, then pulm, but then neurology, then cardiology, and child maltreatment is at the top. So then my first thought was not in alphabetical order. Is it in order of occurrence? Meaning is child maltreatment the most common of the potential causes for BRUE in higher risk infants, which is why you put it so high up in the table? Or is that just a coincidence that I'm reading into this too far?
No, so it's not based on the prevalence or the incidence of any of these conditions. In fact, at the time that we wrote that, we didn't know those things. Okay. Based on some of our research, we do know these things, but again, like I said, at the time, we didn't know those. I will say that there are things that we think are really important that you don't miss, and child abuse is one of them, and that's why it's at the top, because we really, to detect child abuse when it presents subtly and to prevent further harm from happening to that child, you need early diagnosis. And early diagnosis really depends on having an awareness and an index of suspicion, knowing how to ask the right questions, knowing how to do the right physical exam. And so we really want that pediatric hospitalists to be aware of it and to know how to do those things.
Now, in your section, BRUE diagnosis and risk stratification, the interesting parts I pulled out was, again, always do a thorough and complete history and physical. And towards the end of the paper, you spend about 3 pages dissecting out based on the potential causes, what could be in the history and physical, which we'll review. And then if the history and physical reveals an explanation that by definition, the patient now does not have a BRUE. So you manage that diagnosis however you're supposed to. If it's bronchiolitis, you manage it that way. If it's arrhythmia, you manage it that way. And then even for higher risk patients, so again, for those of you listening, I don't want to lose you. So I'm going to go back and quickly read who are lower risk. So age greater than 60 days, gestational age greater than 32 weeks, and post-conceptual age of at least 45 weeks, occurrence of only one BRUE event, no prior events ever, and not occurring in clusters for that specific time. Duration of the event was less than a minute. No CPR by trained medical provider. No concerning history or physical exam findings. Again, for higher risk infants, we'll talk about the flow chart, but the guidance still suggests against routine CBCs and chest x-rays, which was great. And now, once you get past table 2, the next big thing, there's a whole section on the management, but it's the figure 1. And for those of you at home listening, I know you're hate when I when I probably talk about figures on an audio podcast, but I'll do my best to explain it. So now you've diagnosed a BRUE is made. You go through, and the patient is not low risk. So that means they're higher risk. So you're going to perform an initial evaluation in ambulatory or emergency setting. That was the other part that I don't remember spending a lot of time on when I read this. Is you go through in the paper that the initial evaluation and management can occur in the ambulatory setting. It doesn't have to occur in the emergency room or on the floor of the hospital. But you clearly state that if the PCP is comfortable and they're able to do whatever has to be done in terms of follow-up or testing, et cetera.
Yeah, I mean, I think, the benefit of hospitalization is that you can potentially observe the event recur while, let's say while the patient's on a monitor, and then you can better characterize it. And then you characterize it in using medical terminology. So, for example, a lot of patients will be admitted, we'll watch them eat, we'll diagnose it as oropharyngeal dysphagia. Or we'll watch them on monitors and the parents will say, well, there's an event. And then we'll say, well, that's just periodic breathing of the newborn. But there is value in being able to observe the event, particularly when it recurs. Having said that, there's also some problems with admission, right? So putting a patient on the monitor overnight that falsely alarms, and we know that there's a high rate of that, could contribute to the anxiety of the family. And it could also take what is very much a benign, self-limited condition and give the perception that it's something more serious requiring hospitalization. And then the other thing is oftentimes, and even now, we don't know to what extent hospitalization leads to an explanation. So we may hospitalize a kid, and where's the end point for the hospitalization if we're unable to explain it? Even if we recapture it, what do we do? And so there are many cases where it's reasonable to have these patients follow up, particularly if the events don't seem that severe. And, a good example of this is when there's a concern for seizures or epilepsy. A lot of the neurologists will tell you that it's perfectly reasonable to do a seizure evaluation as an outpatient, that you can get an EEG and maybe head imaging if you're concerned that the patient has epilepsy, that admitting them to the hospital won't increase the chance that you'll diagnose epilepsy. Because what really has to happen is the patient has to have recurrent seizures in order to see the pattern and then make the diagnosis, because there's limitations to EEGs. There's limitations to a neurologist's ability to define a seizure. And we all know neuroimaging is typically not very helpful in diagnosing epilepsy unless there's a serious other cause, whether it be child abuse, like accidental head trauma, or there's a brain malformation that's contributing to it.
That's completely right. And I kind of wonder, a lot of times when I have these BRUE patients now, and I have them overnight, and they meet higher risk criteria, and I tell the parents there's nothing happened overnight, child's doing okay. I like to think that it gives a parent peace of mind, but that's just me guessing. I don't know that there's any evidence to show that if they're observed overnight, the parents feel better and are no longer worried about the child. And I don't even know how you would do that study.
Well, I think there certainly are parents where it's not helpful and potentially harmful to admit them to the hospital. And I think there are situations where it is helpful. My belief around this is that this is a really good space for shared decision making. But I think the point where shared decision making has to happen is in the emergency department before they're admitted. And the discussion really, in my mind, should be around, discussing the benefits and the risks of hospitalization and letting the family tell you, where their risk tolerance is. Some families may see coming into the hospital as really exposing their child to unnecessary risk, and some people may see it as being protective. And I think we all know that there's a great degree of uncertainty there. And so how they interpret that really will then dictate whether the hospitalization is helpful or harmful potentially.
And that's very well laid out in the paper. And then so for the initial tier, once we've diagnosed BRUE, if I have to, for what you guys discuss, The reason for the initial tier is you're looking to identify problems that are sensitive to delays in diagnosis and treatment, which to me means you want to identify a bad thing that could happen to a child and intervene if you're able to. And then you talk about that this can be done as an outpatient. And part of the ways that you do that, you recommend continuous pulse ox monitoring for at least 4 hours, a social worker consult to screen for child abuse and mental health contributions, and providing parental support, a feeding evaluation, ideally a feeding therapist, which I have to say in the ER is probably going to be hard to do if you're doing this in the ER. The diagnostic testing is an EKG, a rapid viral respiratory panel, and pertussis in underimmunized or exposed patients in endemic regions and outbreaks, a hematocrit, blood glucose, bicarb, or venous blood gas, lactic acid. And then if you have concern for child maltreatment, like bruising or torn frenulum, a consult with a child abuse expert, CT or MRI of the head, and skeletal survey. What's interesting about this is a couple of things. One, there are a number of things that you should not do for a low-risk child that are on the first tier initial pass for a higher-risk child, like respiratory virus panel testing, the hematocrit, the blood glucose, bicarbonate. But it's a very nice stepwise pattern. And again, the focus is on clearly identifying if you're concerned for abuse, looking for the other areas which we're going to get into. But am I right that the purpose of the initial tier, that initial evaluation, is to identify time-sensitive things that could harm the child and intervene?
Yes. So, and sorry, Tony, the audio was breaking up there. So I'll do my best to answer you. So just going through each of those, that first tier, it really is to find those serious diagnoses where you don't want to miss them and where a delay in diagnosis could be harmful. We do know that continued pulse oximetry for at least 4 hours will detect the vast majority of the serious respiratory conditions. As many people know, it might also be falsely positive, and so I think will require some interpretation of that. The consultation, particularly with a social worker, I think is important. It is a difficult goal to achieve, to get a social worker to evaluate a patient in a timely manner in an emergency department or in the inpatient setting. But really the first reason should be to provide support for a family to just witness something very stressful, and to help them put that into context and provide resources for them. It is also known that social workers do an excellent job of screening for child abuse, whereas physicians do a decent job, but I think a social worker specialist trained in that area more so than even we are. The one thing that I think I've learned most is in taking care of a lot of these patients is that a large number of these patients have problems with feeding. I always consider feeding to be the first developmental milestone that an infant needs to achieve. And it is amazing how many of these infants really are struggling with feeding, and they have oropharyngeal dysphagia. And as a consequence of that, they're getting obstructive apnea either during feeds or shortly after feeds due to ascending or descending reflux problems. And a lot of that can be ameliorated with really just good feeding support at the bedside. In terms of the diagnostic testing, you mentioned a lot of things. We think an EKG is helpful because it picks up prolonged QTC and cardiac arrhythmias. And a lot of that's based on the older studies that show that these kids are at risk for cardiac arrhythmias. We do know kids with cardiac arrhythmias present with BRUEs. We are now learning with some of our newer research the rate at which that happens. And hopefully with some additional research that my group's doing, we'll be able to know when it is appropriate to do that test and under what circumstances. The rapid viral testing that you mentioned, we realize that's not always available broadly, and that can be a problem. But when it is rapid, so for, at Seattle Children's, we can get this test usually within an hour or two in the emergency department. If you have a patient that comes in with, an unknown cause of their event, and then they're RSV positive, you might speculate that they have some clinical RSV, and you can at least counsel the family on anticipatory guidance and what to do and what to watch out for. Clearly, pertussis, which is included in that respiratory panel at our hospital, is very valuable. You mentioned hematocrit. Hematocrit, there's two reasons to do a hematocrit. One is in abusive head trauma, it can be a reasonable screening tool if you see a low hematocrit that they maybe have rapid blood loss somewhere. And so that may be one additional data point when you're looking for child abuse. The other thing is in breath holding spells, which a large number of these events are caused by, can be associated with anemia. You mentioned blood glucose, bicarbonate, venous blood gas, and lactic acid. Those are all things that I think are important when you're considering metabolic disorders. We're not quite sure how often those metabolic disorders happen. So similar to cardiac arrhythmias, we know they can present with a BRUE, but we just don't know what proportion of patients that we're seeing as hospitalists or ER doctors are really signs of something serious like a metabolic disorder. And then I think child maltreatment, again, we've talked about how important it is to consider, but really early consultation with the child abuse expert is important. But honestly, head imaging is going to be your most important test that you do when you are considering abusive head trauma presenting with a BRUE. Other types of abuse do present as a BRUE, and so I don't want to forget those things. So, for example, toxins. So if a patient has been given alcohol or a medication, they can present with a BRUE. And then suffocation injuries. So there are some really terrible case series of Munchausen's by proxy where patients were being suffocated by caregivers and then presenting with BRUEs. And so you don't want to forget those things. And, testing for toxins in the blood is relatively easy at a lot of hospitals. Doing a physical exam, looking for bruising around the face, torn frenulums can be really helpful in detecting whether there's been a smothering injury or forced feeding. So those things are important, but when in doubt, consulting with a child abuse expert if you have them available is also helpful.
Now, you said a lot. That's great. That's half of what I was going to cover next, so I appreciate that. To focus more on the child abuse, just to wrap that up, you guys talk about abusive head trauma can have high-risk BRUE due to central apneic events, but if they delay care, if the whomever is with them delays care, child can appear normal when they see you in the emergency room or even on the floor. You may not have external signs of trauma. One of the things for child abuse in your in your table 3, specifically suffocation, and I didn't have a chance to look this up and I didn't know, was the potential evaluation for suffocation, purposeful suffocation, is a chest x-ray, rarely. And I didn't look up, I didn't have time to check out, but I didn't know why a chest x-ray.
Well, so I'm not a child abuse expert, but my recollection of this is you can see pulmonary edema from repeated barotrauma to the lungs. And so that might be one thing. The other thing is, and I don't know that this is why it was mentioned there, but chest x-ray can be also helpful in looking for rib fractures. And so the important thing to remember about that is that you don't want a single view. If you're looking for rib fractures, a single view will miss the rib fractures. So oftentimes you want an oblique view. So these are all included with your skeletal surveys. So you look at the long bones and then you look at the ribs. So if you're really looking for skeletal trauma, you want to get the right view.
And one of the more sobering statistics you mentioned is that a third of infants and toddlers who present for medical evaluation after an episode of abusive head trauma have been seen previously by a medical practitioner in which the diagnosis was missed. And I unfortunately think a lot of us will end up missing one of these. I know I did at one point very early on in my training, which has stuck with me, but the signs and symptoms can really be very subtle.
Yeah, no, it's like you. I've had one case that we, even as an organization, missed that did not end well, and it really does bias how you approach patients. And I think it's important. The question that I've always been struggling with as I do this BRUE research is, what is the risk that patient you're seeing with a BRUE has child abuse. This is a subtle presentation of accidental abusive head trauma. And, our research group has made great progress in understanding that risk. And in the next episode, we can talk a little bit more about that risk. It's still low, but it's quite substantial. And unfortunately, it is still missed quite often, more than we would like it to be.
And that's a great teaser for the next episode. For those of you at home, we're going to have another episode where we talk more about what the latest research is showing after now this framework for evaluation of higher risk infants. But to continue wrapping this up, there's a secondary evaluation back on figure 1. You've gone through the initial evaluation. You've made sure as best you could that you didn't miss any of the time-sensitive diagnoses and treatments. Now, the second tier is if you have no explanation identified for the first tier, then you want to pursue some sort of more specific workup. You want to go further. And this second tier in the guidelines, it talks about it can be evaluated after discharge, or you can keep the patient admitted or admit the patient if they warrant for a short period of observation in a hospital. And again, that's that shared decision-making, what's best for the patient and the family, and depending upon where you practice, if they're in a very rural setting and they're very far out, it may be just keep them in the hospital if it's too difficult for them to get it. And the second tier workup really is just you're laying out all the potential workup for what the huge differential for this could be. And you laid it out really nicely. So going through it, if you're concerned for GERD, you can get a GI consult. So the groups of specialists that are talked about are GI, ENT, pulmonary and or sleep, child abuse specialists, neurology, cardiology, and genetics, which we've mentioned. So then once you hear those specialists, it should make sense that you test for what test you're doing for: a swallow study, continuous pulse ox, sleep study, prolonged EEG, BMP and ammonia. And there are others if the situation is warranted, such as an upper GI, esophageal pH monitoring, EGD with biopsy, ABG, chest x-ray, brain MRI or CT, echo, again, urine organic acids, plasma amino acids, or plasma acylcarnitines. And you can see how you broke it up. So if you're worried there's a genetics cause, you'd probably consult genetics. You'd get an ABG, maybe, with urine organic acid, plasma amino acids, plasma acylcarnitine. If you haven't gotten lactate pneumonia, you would. Or if you're worried about more of a reflux cause, you'd consult GI. I don't know that I would do an upper GI. I may, looking for a malrotation. But so you can kind of see, and if this is a more oropharyngeal dysphagia, a swallow study for us, a modified barium study, or a video fluoroscopic study of some type. But you lay it out very, very nicely in terms of what the next steps are. And so it's really for foolproof for anyone evaluating one of these childs, whether they are new in training or have a lot of experience with kids or very little experience with kids. Was that the purpose of this, to really make it easy for people?
Yes and no. The key part to this is to do these things based on your understanding of the event characterization. So how you characterize these events. It's not intended to be read as do all of these things. It's really intended that if you have concern for this, then you do this. So and doing all of these things on each patient would definitely be low yield and would subject the patient to a lot of radiation, a lot of pain, and unnecessarily so. I can say that, so a lot of times based on the characterization, you can have a concern for silent aspiration due to a feeding problem. And that having a speech language pathologist do some bedside evaluation can go a long way. And if you, for example, have concern that there's noisy breathing, and maybe you think this kid has laryngomalacia, which actually a large number of these kids do have laryngomalacia, that having ENT, at least at our organization, come by and do a bedside scope is pretty easy and gives you a lot of information really fast. And it certainly rules out laryngomalacia. And as we'll talk about in episode 2, laryngomalacia that needs surgery is actually fairly common in these patients. And so that would be an important diagnostic evaluation to consider. You talked about, Tony, the value of evaluating for reflux, and I do think it's worth focusing on this just a little bit. If you do an evaluation for reflux, so an upper GI, on these patients, you will see a positive result. But it doesn't mean that that's what's causing the event. And this can be bad, right? It can lead you down the wrong diagnostic path. It can expose the patient to radiation. You have to admit them to the hospital. You have to make them NPO, and you have to do all these things to get that study. And in the end, what you're really documenting is something you already know, which is that infants have reflux. So we don't recommend that you really ever get an upper GI if your intent is to look for reflux. If you're looking for malrotation, volvulus as a cause of a BRUE, which that can happen, then that may be a reasonable study. But again, not to look for reflux. I just want you talked about seizures in an EEG. And I will say the neurologist on our group, Josh Bonkowski, really in his research has demonstrated that there's not a lot of yield in doing an EEG while the patient is inpatient compared to doing it while there's outpatient. There may be some benefit to the family in terms of shared decision making, but in terms of early diagnosis and outcomes, there doesn't seem to be a clear benefit in doing it while they're inpatient.
Now, one of the things that I agree with everything you said, Joel, absolutely everything you said, that was great. And one of the things I picked from this that I don't know that I think about very often, and I like to bring those up because it's just something that, I'm talking on the podcast, and I'm going to bring up stuff that I really don't think about very often. And obstructive sleep apnea, because that came up a few times in the guidelines. You had a section in the guidance in the paper, and it says OSA, obstructive sleep apnea, can be seen in infants with low tone, problems with secretion management, or certain hypotonia, reflux, and craniofacial abnormalities. And, it may be like one of my colleagues here, Dr. Kishore Velodi's the head of our Down Syndrome Center for Western Pennsylvania. Kids with Down syndrome have a higher incidence of obstructive sleep apnea. So he's someone that may regularly screen for OSA in an infant that he knows has Down syndrome that comes in with BRUE. But I can say it's not something I think about often, and I like that it was in there to really kind of bring it out. In your research, have you noted anything in terms of OSA as a frequent cause or just very infrequent?
Yeah, no, and we'll talk a little bit more about this in the next episode. But what we have seen in our research is that OSA can present with a BRUE. So it could be due to the facial structure. It could be due to, like you said, low tone, large tongue, those sort of things that tend to cause OSA. In this age group under a year of age, most of those things are uncommon because there's not the tonsillar hypertrophy or adenoid hypertrophy that sort of contributes mostly to those things. But it certainly is possible. A lot of the time, like a child with trisomy 21, the diagnosis is much more easily made because they're at risk for it. But these things can rarely happen in an otherwise normal appearing child that doesn't have a genetic syndrome.
And I guess I'm going to round out the discussion. I'll give you a chance to bring up anything I didn't, talking about table 3, which I really like. This was the big 2-page table, and it goes through each of the sections we kind of talked about, and it has 4 columns. And then what you would see on history. So quickly, for oropharyngeal dysphagia, there would be chronic, severe, or recurrent feeding problems. What you would see on physical exam, coughing, choking, or gagging during or shortly after feeding. And what you would see is the potential evaluation, in the evaluation, primary careful feeding history, bedside evaluation by feeding specialists, and some video fluoroscopic study for feeding as a secondary test. And especially for those of us in centers where we have residents, medical students, or even nurse practitioners, who's anybody, this table is a really nice summary of what you'd look for on history, physical, and what you would evaluate for patients with this type of a problem. So I liked it a lot. So Joel, is there anything we've gone through a lot of it? Is there anything we did not discuss that you wanted to go over that we're not going to talk about?
I do want to talk a little bit about the risk criteria, just to go back you talked about the lower and higher risk. We talked about CPR, and we talked about age, and we talked about prematurity. One other important point is how frequent, or if they've had multiple events. So to be lower risk, a patient must have had only the one event they're coming to see you for. If they've had more than one event, so they're repeating over time, whether it be that day or a week prior, then they really cannot be put into the lower risk group. And the same is true as if they have a cluster of events on the same day. So let's say they have 3 or 4 events back to back. That's considered multiple events, and they can't be put into the lower risk group. And I think that's an important distinction. We do see that missed quite frequently, at least at our hospital, where people will misinterpret that. There's another question that I get asked quite frequently, which is the event duration. So for the risk criteria, we say in the guideline that it needs to be under a minute to be considered lower risk. And that was based on the best available evidence at the time, where those studies felt like they could accurately detect the event duration as described by the people bringing the child in. I think what we've learned in practice is that most of the time that estimate is inaccurate. That, if how many people can actually draw the line at 60 seconds being more or less. And so we were somewhat concerned as a committee about, drawing the line there, but the evidence indicated that we should. I use that pretty cautiously because in my practice, I've rarely been able to get a parent to say, was it more than 60 seconds or less than 60 seconds in some degree of sort of objectivity or accuracy. Sometimes it's very easy for them to say, oh, it was very short and it was very brief, which is really the intention of the term Brief Resolved Unexplained Event. But I just caution people about, hanging their hat on the 60-second mark.
So if there's one you have a little leeway with, it's that. You're right. Parents are probably not going to know. Unless it was a couple seconds.
Yeah. And you also mentioned, Tony, the recommendation to teach CPR. And we'll talk about this a little bit more in the next episode. But what we're learning so what we know from an evidence standpoint is that parents do feel reassured overall when they know CPR, and it reduces measures of anxiety. We don't know that specific to BRUE, but the guideline committee felt that it was reasonable to provide CPR training to families. The pushback we frequently get, or the concern we get from providers, particularly at the ER, is that if they recommend CPR training, they're worried that they're implying that the event was life-threatening. And that's really not the intent of that. The intent really is to empower families to know how to take care of their child should they choke or gag or need CPR. But it's really not this. So the messaging needs to be clear that what we're really saying is, this is a tool that you'll have. We don't think you're going to need it, but we want to provide it to you. The other piece to that is really, if you're not able to provide CPR training, one thing that can be very helpful is to go over airway clearance with the family. We know that as kids are learning to eat, they choke and gag frequently. And even the younger infants, they'll choke on their formula, or as breast milk comes in, or they get a different nipple size. And so just knowing as a parent, how to manage that and when to be concerned and when not to be concerned is, I think, very helpful to review with the family.
Okay. Well, that's great. Now, Joel, we did forget to do our corny joke segment.
Okay. I got one for you.
I got one for you as well. You want to go first or second?
You go first.
All right. Well, a pig that does karate.
You got me.
Pork chop.
God.
I do love. All right, you're up.
Yeah. How do you get a Kleenex to dance?
Oh, I know this one, but I'll say no. Go ahead.
You put a little boogie in it.
I've used that one in the past.
Oh, wow. And I'm glad to know they circulate through society.
Joel, I've gone through everything, almost everything in my notes set. Is there anything else? Thank you for bringing up the things we didn't and going over a couple extra things. Is there anything you want to discuss further?
I think we covered it all.
As not a person who was on the paper, for those listening, especially the higher risk infant paper in pediatrics in 2019 is really a good read. It goes through in very nice detail, and after reading, you refresh your memory on things maybe you haven't seen in a while, and just go over things that you haven't really seen very much at all. So I enjoyed reading it. So thank you.
Thank you. Yeah, and I would just like to acknowledge all the people that have helped out with this work. Each committee, the BRUE committee from the AEP, and the committee that wrote the framework for higher risk infants, is a huge number of people, lots of specialists, and people that are really dedicated to making care for these kids better. And I wish I had the time to list them all out. I do want to highlight, though, that Lawrence Merritt, who was the first author of the framework paper, did an amazing job putting that together. And believe it or not, he is a metabolic geneticist who is so dedicated to this work that he put that paper together in such amazing fashion.
That's great. That's really great. So, Joel, I want to thank you again for being on the podcast, and thank you for agreeing to be on it again in the future.
My pleasure, Tony. Thank you so much for having me. I really enjoyed it.
Oh, my pleasure. Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, TONY.Tarchichi, TARCHICHI, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.